So the next speaker, which will be in the format of a recording, is then Dr. Systrom. And I think he was also part of the program, the last year maybe, although I was not moderating that session, unfortunately. But now we will hear Professor David Systrom from Brigham and Women's Hospital, Harvard Medical School in the US, talk about neurovascular dysregulation during exercise in ME, CFS and long COVID, and the LIFT trial. So we'll see what the LIFT trial is. So we just push play, I guess. Please.
Hello, everyone. I'm Dr. David Systrom. I'm at Mass General Brigham Hospital in Boston and Harvard Medical School. And I'm sad to say I couldn't join you in person this year for family reasons. The good news may be that the clinical trial I'm going to tell you about toward the end of this talk, we are very much hoping will be completed a year from now. So maybe I'll have more to share and perhaps in person a year from now. But for now, what I'd like to do is tell you about some of the basic tenets of our thinking about what ails patients with both ME, CFS, and long COVID during exercise, and why we've chosen two particular drugs to pursue as part of the so-called LIFT trial funded by Open Medicine Foundation, which is ongoing, and I will come back to at the end. But first, the basis for choosing, and I'll cut to the chase, pyridostigmine, also known as Mestinon, and low-dose naltrexone alone or together. And to summarize briefly, we believe there's evidence of neurovascular dysregulation during exercise in both diseases, and that both of these drugs have the potential to treat that particular pathway and pathophysiology. I have one disclosure for you, a little bit of tongue-in-cheek. I am Swedish, at least partly, I'm told by a variety of people, including my grandfather, and please take that into consideration. So here's a table of contents about what I'd like to cover over approximately 25 or 30 minutes. The first is the notion of the circulatory dysfunction and then linking it to neurovascular dysregulation. And to do so, our major vehicle for investigation of exercise intolerance in both ME and long COVID is the so-called invasive cardiopulmonary exercise test, or ICPET. It is something that we helped develop over 30 years ago for the investigation of early pulmonary hypertension and heart failure and differentiating heart versus lung disease. But over the past decade or so, we have found it exceedingly useful in taking a deeper dive into the pathophysiology of exercise intolerance in these two diseases. And I will cover sequentially, and this is chronologically how we've discovered things, something we call preload failure or preload insufficiency. Then a more recent concept, which is on the arterial side of the heart, the systemic arteries, which is impaired systemic oxygen uptake or utilization. I'll give you some reasons, potential reasons for that, and then we will show you the protocol for LIFT, and I'll give you an update on our recruitment. So the invasive cardiopulmonary exercise test, I don't need the audio here. I wonder if I can get rid of that. So just to show a couple of the key features here, many of you are very much aware of the non-invasive variety of a cardiopulmonary exercise test. In our case, we use a cycle ergometer. That's in part to keep the patient stable, who has two catheters in place. It also smooths out the increment in metabolism, or VO2, and a variety of thresholds that we can detect during exercise, as opposed to discontinuous treadmill-type testing. So this is our preference. In this gentleman's mouth is a pneumotachograph measuring his minute ventilation, that's breathing, bulk flow of air, and then the catheter. Emanating from that is sampling his expired gases. That's oxygen uptake and CO2 output at the mouth. What makes the invasive test special, as the name implies, are the two catheters. So one you can see in his left wrist coming and going over here. That's a radial artery catheter, and the other is a pulmonary artery catheter whose tip resides in a medium-sized pulmonary artery introduced with ultrasound guidance in the cardiac cath lab around the corner through the internal jugular vein. It's quite safe, virtually painless, and we've done surveys and patients are actually quite happy with the comfort factor after this, and it gives us a phenomenal amount of information. Many in the business would be worried about precipitating post-exertional malaise with this type of test. Generally speaking, it's 6 to 8 minutes long. The intense part is only the last minute or two, and it's very unusual for us to precipitate a significant crash or bout of PEM. All right, this is the diagnostic algorithm for our testing. Some of this is non-invasive, and I'll point out which, and then some of it is derived from the two catheters. The first is the VO2 peak. We express that as a percent predicted. The normative equations come from the patient's age, sex, and an assessment of muscle mass, lean muscle mass, which is derived from the height. Generally speaking, a peak exercise VO2 or a VO2 max of greater than 80% is normal or low normal. But I will say quickly that in ME and long COVID, we have patients who come in at 90 and 100%, and we still discover abnormalities that are treatable. So please don't write any patient off because their non-invasive VO2 peak is 80% or better. We can rule out a pulmonary mechanical limit non-invasively. This is basically the difference or the ratio of the minute ventilation at peak exercise divided by the ability to move air in the resting state, so-called maximum voluntary ventilation that can be measured or calculated. And as one creeps up with a high number, generally speaking, this is associated with breathlessness and greater than 70% of capacity at peak exercise we denote as a functional pulmonary mechanical limit. This is not germane to the type of patients I'm going to be talking about today. This is a minority of patients with long COVID and almost no one with ME/CFS. The capacity to breathe is normal and the ratio at peak exercise is low. There would be select cases perhaps in long COVID with fibrotic lung disease, but that would be a smaller subset that I won't be talking about today. The rest of the world is explained by something called the Fick principle that's shown here. It dictates that the VO2 peak, and at any point in time, but including peak exercise, is going to be derived from the cardiac output, the QC, and the difference between arterial and mixed venous oxygen content. Normally during exercise, the cardiac output goes up about 5-fold from rest to peak exercise. And normally the arterial oxygen content stays constant at about 19 or 20 ml per deciliter, and the VO2, which is the mixed venous oxygen content, falls about 3-fold from resting values, reflecting uptake and utilization of oxygen delivered to the largely to the exercising muscle mitochondrion. We derive a cardiac output, the so-called Fick cardiac output, by measuring this at the mouth, this at the radial artery line, and this from the tip of the pulmonary artery catheter. And we can express the cardiac output, the Fick cardiac output, as a percent predicted. It's going to be very important in understanding what I'm about to tell you to note that what we are actually measuring with the Fick cardiac output is the pulmonary blood flow. So VO2 at the mouth, and then the difference in oxygen content across the lung. If there is no shunting going on, that will be equal to the systemic blood flow, but we have some notions about how there is a disconnect between those two. I'll come back to that in a minute. So generally speaking, if we have a low VO2 peak and a low cardiac output, we can flow down here, determine whether the patient has left heart disease or right heart disease by pressures. So this is the pulmonary capillary wedge pressure. It's a reflection of left heart filling. High is bad. It reflects left heart disease. This is an upper limit of normal for an individual age greater than 50. We can detect pulmonary hypertension by measuring the mean pulmonary artery pressure and then calculating a resistance. If these are both high and the cardiac output is low and the VO2 peak is low, we're entitled to infer that there is pulmonary hypertension that's limiting the patient. We don't see a lot of this in ME, virtually none, unless there's superimposed disease. Either of these things. This is largely heart failure, preserved ejection fraction in the general population. This is a rare disease in general, pulmonary hypertension. Very little of it in long COVID. There's an occasional persistent blood clot. Very little of this in long COVID. There's an occasional cardiomyopathy, but these are rare cases, and I will not be talking about them today. Where our patients with ME and long COVID end up are these two places, and I'm going to take some time to explain it. So preload insufficiency is low filling pressures. It's really biventricular filling pressures, but I'm going to emphasize for simplicity the right atrial pressures today. Our lower limit of normal at peak exercise in the upright position is 6.5 millimeters of mercury. And then the other contribution to impaired VO2 peak and symptoms in some patients, and as you'll see as we go, predominantly women, is inadequate oxygen uptake in the periphery, failure to depress the mixed venous oxygen content normally. And this is a hallmark of something called left to right shunting, and I'm going to make a case that this is peripheral. So we're going to be focusing here and here as we go. All right. The first thing that we discovered in the ME-CFS population was something we have called preload failure or preload insufficiency. And with the help of Will Oldham, who's now directing a lab at Brown, we took a dive into this about a decade ago. And because of referral patterns, we were largely being referred patients with unexplained exertional dyspnea or breathlessness. But as we found out when we further interrogated these patients, they also had fatigue and PEM and met major and minor criteria from the Institute of Medicine for ME-CFS, the majority of patients. And what we asked was after doing an invasive CPET and ruling out any classic heart or lung disease, as I just described with our algorithm, is there a population who is suffering symptoms and a depressed VO2 peak not due to heart or lung disease? And the answer was yes, and we had a cadre of normals to compare to. And this is what we found differentiated our normal cadre of patients from the impaired patients. Again, the impaired folks had low VO2 peaks, no heart or lung disease, and we learned retrospectively met criteria for ME-CFS in large part. What differentiated them was filling pressures. So here's right atrial pressure, upright. You lose the signal if you do this supine in the right heart cath lab. And it is mostly at peak exercise, not as robust in the resting state. So low right atrial pressures are a hallmark of this disorder. And low left atrial pressures, the surrogate is the pulmonary capillary wedge pressure at peak exercise over here. And if we regress those filling pressures against the time-honored VO2 peak or max and the cardiac output max, the lower the filling pressures, the lower the cardiac output, the lower the VO2 max. So this is what we called preload insufficiency, and this is where they ended up in our diagnostic algorithm. The next thing that we determined, and this is now about 4 years ago, with the help of Philip Joseph, is that additionally, by the Fick principle, there's a subset of patients who have not only preload failure, but impairment of oxygen uptake and utilization in the periphery, and this is what we published in 2021. And to cut to the chase, this unique subset, there is the preload insufficiency shown over here with a very low cardiac output versus VO2 lower than normal, shown here in gray. Again, the slope during incremental cycling exercise. It's where 160 patients with ME-CFS. But additionally, there is a subset we call high flow. And remember, this is pulmonary blood flow, so very high pulmonary blood flow throughout incremental exercise, higher than normal, higher by definition compared to an intermediate group or the pure preloaders. And the reason that their VO2 peak is low is that there's impaired oxygen extraction by the Fick principle, and that's shown over here, corrected for the hemoglobin. So we looked at this, and this was frighteningly familiar to us in the cardiopulmonary world. This looks like an atrial septal defect with shunting of oxygenated blood over to the venous side, where it goes around and around in the pulmonary circuit, but is not getting out to the periphery, where it can load up the mitochondrion with oxygen to do its thing. So here's a little cartoon showing intracardiac left to right shunting through an ASD, a form of congenital heart disease that one can discover in adulthood. But we know our patients don't have that. We know that because there is a specific measurement made during the resting right heart catheterization that measures any potential step up from the superior vena cava to the right atrium through the right ventricle and then on out into the pulmonary artery. If there's a step up in oxygen, that helps define an intracardiac left to right shunt, and we don't have any of that. What we think we have is a peripheral shunt. This is the skin showing the epidermis and the dermis with the vessels underneath, and we are all endowed by potential AV shunts. They're shown here. They can open and close. They're surrounded by small fiber nerves that secrete either vasoconstrictors or vasodilators, and this amount of shunting through the skin, for instance, can be dynamically regulated or even dysregulated in disease. This isn't the only place this can happen. There is potential for this happening in the gut and the kidney, and even microscopically in the skeletal muscle. So peripheral left to right shunting, though, is our theme here. This is a more recent look at some of the Fick principle variables in a larger cohort of ME/CFS, about double what I showed you in the Philip Joseph paper, and a newer cadre of patients with long COVID, all of whom have undergone the invasive CPET versus a larger population of normals. And to cut to the chase here, I've got peak VO2, peak cardiac output, the peak right atrial pressure upright, and then systemic oxygen extraction here. These are the normals in the green, and what you can see is that there is an identical drop, at least on average, for both long COVID and ME patients of VO2 peak, cardiac output, right atrial pressures, and systemic oxygen extraction. But you can also see a lot of variance around the mean. For instance, here's that high flow group shown down here with, here's the high flow group with impaired oxygen extraction down here and a higher cardiac output up here. So we are further drilling down on this enlarged database, which reflects the last 5 years of our invasive CPETs here at the Brigham. This was presented by Johanna Squires, master's level exercise physiologist at American Thoracic Society last May in San Francisco. All right, so a little bit more on small fiber neuropathy. With the Philip Joseph paper, we were becoming increasingly aware that many of the patients referred to us had had a skin biopsy that documented small fiber neuropathy. And this is a picture of a normal individual, specially stained, unmyelinated neurites in the epidermis, and this is missing in action and defining the presence of a small fiber neuropathy. So what we know about these fibers in the skin is that they're unmyelinated, they're C fibers, they mediate nociception or pain, but what's increasingly becoming appreciated is that they also mediate blood vessel tone in the body and therefore blood flow. There's a high prevalence estimated at around 40% in things like fibromyalgia and a form of dysautonomia called postural-orthostatic tachycardia syndrome. It's also known that there's a higher prevalence associated with autoimmunity and associated inflammation. So we've asked the question, what is the prevalence of small fiber neuropathy in our patients with ME and long COVID with these blood vessel abnormalities during exercise that I've just described. And here's our most recent look at this, presented about a week and a half ago in Amsterdam by Johanna Squires again, and our more recent look. So 400 patients with ME, 55 with long COVID, and we've got definite or probable small fiber neuropathy. The definites are defined by skin biopsy positive. The probables are defined by functional tests for small fiber neuropathy like the QSART or electrical impedance. And the answer is up 2/3 or even 3/4 of patients appear to have small fiber neuropathy in addition to the blood vessel abnormalities during exercise that I've described. So we're inclined to link these things. This is where our patients end up with this new notion of peripheral left to right shunting, but additionally the preload failure. And I'm going to give you one other paper that we have published that I think begins to build a case for neurovascular dysregulation in both ME, this is ME, and long COVID. So this was a prospective study commandeered by Philip Joseph, now at Yale, where we had patients with clinically defined ME/CFS pedal away during a clinically indicated invasive CPET. And then they were randomized after consent, of course, to pedal again. And they pedaled again 45 minutes after the first one with existing catheters still in place. Stigmine, Mestinon, 60 milligrams by mouth. So this is proof of concept. As you'll see, effect sizes are small, but we borrowed from some POTS literature. Dr. Raj et al. Showed that an upright tilt table test that the heart rate response was mitigated in POTS if you gave a single dose of Mestinon 60 milligrams by mouth 45 minutes or an hour before a second tilt table test. So we borrowed from that and asked the question, is there any evidence that any of the what we suspect is neurovascular dysregulation is favorably affected, as we think it is in the clinic, acutely doing the invasive CPET? And the answer was yes. If they got drug, pyridostigmine shown over here, and pedaled a second time, the VO2 peak actually went up compared to the first one. If they got placebo, it actually went down, maybe the beginnings of PEM. And the way the peak VO2 went up by the Fick principle was cardiac output. And again, the way it went down, if they got placebo, was cardiac output. And then finally, the way the cardiac output was modified was improvement in filling pressure. This is the right atrial pressure, which was favorably affected by drug and got worse if they did not get drug. So pyridostigmine, we think, in this disease works at the sympathetic ganglion. This is a cholinergic step, and you may remember from your neuroanatomy that there is an adrenergic postganglionic fiber that goes out to, amongst other things, blood vessels. And we think the way right atrial pressure and cardiac output got better with this placebo-controlled randomized clinical trial was favorably affecting sympathetic outflow with a cholinergic step in the sympathetic ganglion. So this has begun to build a case in addition to our anecdotal favorable responses of ME and long COVID to Mestinon in the clinic for the LIFT trial. So what I've tried to make a case here in the beginning of this talk is that there is circulatory dysfunction in both diseases, and that the nature of that circulatory dysfunction may be in part neurovascular. I will tip my hat to others, and I believe there are other potential pathways for circulatory dysfunction, everything from endotheliitis to microclots to basement membrane thickening that the Boost lab you'll be hearing from has found in these diseases, so structural and functional impairments. But I believe neurovascular dysregulation should be on our list of pathophysiology. And I have built a case for that by showing you preload failure and peripheral left to right shunting with impaired oxygen extraction, a high prevalence of small fiber neuropathy, And then when we give a neuroactive drug, pyridostigmine, we get partial correction, at least, of the preload failure. All right. So I'm going to turn to the LIFT trial. This is ongoing, so I cannot give you any results. We are doubly blinded. We'll not be able to crack the code until the last patient is completed. But I'll show you the protocol, and I'll give you a little bit of an update on recruitment here. So again, a special nod to Linda Tannenbaum and Open Medicine Foundation, Jonas, who's part of all of this, whom you've just heard from, I believe, have all helped with the funding and the study design here. So we are seeing both patients with ME and long COVID who meet Canadian consensus criteria for ME CFS. So it's a subset of patients, but a majority of patients with long COVID and ME. So we are looking at 4 different treatment arms and a 1-to-1 to 1-to-1 ratio. So there is pyridostigmine plus low-dose naltrexone, which I'll be talking a little more about, pyridostigmine monotherapy and placebo, low-dose naltrexone plus placebo, and then placebo and placebo, all over 3 months with a variety of outcomes I'm going to show you. So here's the dosing. Asked forever, what doses are we using? We've borrowed largely from the Scandinavians on the low-dose naltrexone dosing, which will be 4.5 milligrams escalated over 4 weeks. And the dose of pyridostigmine is 60 milligrams of the intermediate release 3 times a day, again scaled up gradually over 4 weeks. And then for the remainder of the 3 months, they stay on that dose unless there are purported side effects, in which case we have the ability to step down. I believe we've had to step down in only 2 patients due to purported side effects. So here are some of the outcome variables that we're doing. We are doing a variety of omics, including proteomics, metabolomics, not shown transcriptomics. The Cornell folks, Maureen Hansen et al., are going to look at peripheral blood mononuclear cells. We have a variety of well-validated questionnaires, including FunCap, Promise 29, DePaul PEM, and Brain Vital. Special nod to Dr. Sommerfeld from Norway, who has helped with the FunCap and capturing PEM along the way. We have a wearable device, which is the Garmin Vivo Smart. Variety of physiologic functions are measured. And then we have some solid physiology with the so-called shape test. This is a 3-minute step test that I'll show you in just a second with a metabolic cart. So these are 2 of our exercise physiologists. This is the shape test. It's only 3 minutes. It does not precipitate PEM. And even those with orthostatic intolerance get to hold on here. Metabolic cart is almost identical to that in the invasive and non-invasive cycling test. It was made by the progeny of medical graphics. And it gives us a variety of the reflections of oxidative capacity and ventilation and heart rate recovery. And we do that at the beginning of the LIFT trial and then at the end. So that's all I have to show you. I did want to say, as I'm thanking our extended team here, that we are about 1/3 of the way through the LIFT trial. We hope to be 50% of the way through of the 160 projected patients by the end of this calendar year. And then I'm hoping that we will have completed 160 patients by the time of the Swedish meeting a year from now. Special thanks to a variety of folks. These are our current team at Mass General Brigham, Johanna, whom I've mentioned, Sarah, and Sophia, newer arrivals who've been fabulous in recruitment. Our computational team, Wenzong and Peng, out of Mass General Brigham and Stanford, Philip Joseph at Yale, Peter Novak, our neurologist, helping us out with the small fiber neuropathy angle from the Brigham Faulkner. The late Ron Tompkins, who put this all in motion, Ron Davis, Stanford, Maureen, I mentioned, Jonas, I mentioned, Alan in Montreal, Chris in Melbourne, Australia, Bob Navio, mitochondrial expert, at UCSD, and then Linda and Danielle, fabulous folks at OMF. Special thanks to all of them and to all of you for paying attention, and we hope to report back in a year. Thank you.